Testing, testing, 1, 2.
The meeting will come to order. Good afternoon. Thank you for coming to this organizational meeting of the Health Subcommittee of the 112th Congress. It is my hope that this meeting will be short so we can move right along to begin today's hearing. An agenda for this meeting was distributed to the members in advance. This meeting is open to the public, and there will be an official transcript of the proceedings. We have a good mix of members on the subcommittee this session, and I'm honored to be able to serve as your chairman. I'd like to introduce the Republican members of the subcommittee. To my right, Mr. Johnson of Texas, Mr. Ryan of Wisconsin, Mr. Nunes of California. We also have a number of members who are new to the subcommittee, Mr. Reichert of Washington, Mr. Heller of Nevada, Mr. Roscom of Illinois, Mr. Gerlach of Pennsylvania, and Dr. Price of Georgia. On my left, we have the ranking member for the 112th Congress, Mr. Stark of California. Mr. Stark, I look forward to working with you and all of our members. Would you care to introduce the members on your side?
Thank you, Chairman Herger, for yielding. While we have our differences on policy, I look forward to serving together. You and I have already introduced our first bipartisan bill to reduce Medicare fraud, and we'll continue to look for ways that we can work together. It's a good one to start with today because we've always valued MedPAC's input to help us make our own decisions. And without further ado, I'll introduce my Democratic colleagues at this time. And as there are only 5 of us, it won't take very long. Immediately to my left, figuratively speaking, is my friend Mike Thompson from California. And absent doing the people's work for Wisconsin is Ron Kind. Earl Blumenauer from Oregon is not with us right now. And Bill Passerell from New Jersey. All 5 of us served on the Health Subcommittee last Congress, and we look forward to working with you again this Congress.
Thank you. And now I'd like to introduce the subcommittee staff. Dan Elling, Staff Director, Jill Schmaltz, Senior Professional Staff, Brett Baker, Professional Staff, Laura Bozell, Professional Staff, Liz Lawrence, Professional Staff, Marty Reiser, Professional Staff, Brian Sutter, Professional Staff, and Nick Ulecki, Legislative Assistant. Mr. Stark, would you care to introduce the Democratic staff on your side?
Thank you, Mr. Chairman. The staff that you should notice are Sibel Bjorklund, who's Staff Director for the Health Subcommittee in the minority, Jennifer Friedman, who's Deputy Director for us, Lauren Aronson, who's on our professional staff, Debbie Curtis, who's my Chief of Staff and shared staff with the Health Subcommittee, and Hannah Naprash, who serves with us. We have 2 fellows, Aaron Richardson, a David Winston Fellow with us this year, Sherry Hoffman, an AAAS Fellow with us through the year. We'll have a CMS detailee starting soon and hope to fill the gap left by Jeff Gerhardt, who's gone on to Health and Human Services to help implement health information technology. Thank you, Mr. Chairman.
Thank you. I expect the subcommittee to have an active agenda this Congress. In particular, we will closely examine the new health care overhaul and its impact on the economy and job creation, on those who are currently insured and like what they have, on current Medicare beneficiaries, on health care providers, and on federal spending. We will also examine the importance of repealing the new health care law and replacing it with common sense policies that reduce the cost of health care insurance. While I do not expect to have bipartisan agreement on this issue, it is what the vast majority of the constituents I talk to in my Northern California congressional district are demanding, and I look forward to having a robust debate from both sides. In addition, the committee will look for ways to improve the Medicare program to ensure its sustainability for current and future beneficiaries. The committee will also examine policies that reduce the cost of health insurance, increase health care quality and improve outcomes, encourage transparency, and eliminate waste, fraud, and abuse. In addition, I look forward to working with members on both sides of the aisle to consider proposals you may have that fall under the subcommittee's jurisdiction. I'm hopeful that during the course of the Congress, we will be able to find ways to work together on important legislation like reforming Medicare physician payments and reducing waste, fraud, and abuse in Medicare. These issues do not have to devolve into partisan bickering. As we all agree, they must be dealt with in a responsible manner. I believe, as Ranking Member Stark and I proved last Congress with passage out of the House of our bipartisan Medicare anti-fraud bill, there are ample areas of agreement. On a procedural note, as in years past, the subcommittee will operate under the same rules as a full committee for hearings and markups. At hearings, the chairman and ranking member or their designee will each make an opening statement before we hear from the witnesses. Other members may submit written statements for the record. The chair intends to require both witnesses and members to adhere to the 5-minute rule for testimony and questioning. The subcommittee will follow the Gibbons rule, which means that members who are here for the gavel that opens the hearing will be recognized first in order of seniority.
Okay.
There may be occasions when time allows that we will proceed with a second round of questioning. On occasion, and pursuant to committee rules, other members of the committee who are not on the subcommittee and other members not on the committee may join us at a hearing. At this time, I'd like to recognize Ranking Member Stark for the purpose of his statement.
Again, Mr. Chairman, I just want to repeat that we look forward to working with you in this Congress as we did last term, and appreciate your leadership.
Thank you, Mr. Stark. Does anyone else have any brief comments on the subcommittee's potential agenda or other process matters or anything else for the good of the order? If so, I'm happy to recognize them at this time. Thank you, and thank you for attending this meeting today. I look forward to working with all of you in the months ahead. With that, the organizational meeting stands adjourned.
Good job.
The subcommittee will come to order. I want to welcome everyone to the first hearing in the Subcommittee on Health for the 112th Congress. Today we will be hearing from the Medicare Payment Advisory Commission, MedPAC, on the recommendations of their March 2011 report on Medicare payment policies. During this Congress, we must come together to address a fiscal crisis of monumental proportions. Every program, no matter how important, must be scrutinized to ensure that scarce taxpayer dollars are being used appropriately and efficiently. Therefore, I find it fitting that in our inaugural meeting, we would hear from MedPAC. The insight and guidance we receive from MedPAC will be very important as we seek ways to reform the Medicare program and improve the accuracy of provider payments, while also ensuring that Medicare beneficiaries have access to high-quality care. Congress relies on MedPAC's Medicare provider payment recommendations because they are based on sound policy and strong data analysis. Traditionally, Medicare spending has outpaced growth in the economy at large and is a major driver of our long-term debt. The Congressional Budget Office projects that Medicare spending will nearly double as a share of U.S. economy over the next 25 years. By 2050, the big three federal entitlement programs, Medicare, Medicaid, and Social Security, are projected to exceed total tax revenue, with Medicare being the largest of the three. We cannot bring about a fiscally sustainable future if these trends continue. MedPAC's analysis is invaluable in helping us better understand when growth in Medicare spending is appropriate and when Medicare payments need to be adjusted. Last year, Congress passed a massive health care overhaul law that permanently reduces Medicare payments to a number of providers. Less than 3% of the more than $1.5 trillion in cuts from Medicare came from actual delivery reforms. We must do better than that, which is why we also rely on MedPAC's June report to Congress to guide us toward proposals that offer real reform instead of just turning payment dials up or down. This will help ensure that Medicare savings yield better outcomes for Medicare's beneficiaries. I think I speak for all of us up here, Republicans and Democrats alike, that we are still looking for the silver bullet that will permanently reform the physician payment system in a fiscally responsible manner, and look forward to working with MedPAC to find such a solution. I want to offer a warm welcome to our invited witness, MedPAC's Chairman Gled Harkbarth. Thank you for joining us today, and I look forward to hearing your testimony. I'd also like to extend a special word of thanks to MedPAC's Executive Director, Mark Miller, and the entire MedPAC staff for their hard work on this report. Before I recognize Ranking Member Stark for the purpose of an opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objection, so ordered. I now recognize Ranking Member Stark for his opening statement.
Thank you, Mr. Chairman, and I'd like to join you in welcoming Glenn and MedPAC. It's the efforts of MedPAC and their staff that have helped us in the past. Many of the recommendations in the current law's provisions are MedPAC's work, and they have formed a number of the reforms that are in the law that modernize the delivery of health care, that better rewards value over volume and encourages better coordination. They've helped us with ideas to lower the rate of preventable readmissions, the testing of bundled payments, medical homes, and hospital value-based purchasing. We've made difficult decisions in order to rein in rising healthcare costs, and it would not have been possible without the advice of MedPAC. The end result is a program with improved benefits that lower costs for beneficiaries, create taxpayer savings, and innovations that we hope will improve patient care and strengthen finances for the Medicare solvency for an additional number of years. This, we think, is better than a program that favors vouchers or shifting of costs to the very beneficiaries whom Medicare was created to serve. While my Republican colleagues and I have many areas where we disagree, there are several areas where we work together, including Medicare's broken physician payment system. The House Democrats passed comprehensive reform for the physician payment system in the last Congress, and I hope getting a long-term solution is at the top of our to-do list. As this year progresses, I look forward to getting continued input and advice from Mr. Hackbarth and the MedPAC staff, and will continue to rely, Glenn, on your expertise and advice as we undertake our Medicare oversight responsibilities. Thank you, Mr. Chairman.
Mr. Hackbarth, I want to thank, anyway, I'd like you to go ahead and proceed with your testimony. We do have two votes going on now, so I'd like to have you maybe give your testimony, and then we'll recess until following those two votes, then we'll come back. But if you'd proceed with your testimony, please.
Thank you, Mr. Chairman, and Mr. Stark. I especially appreciate the warm welcome and the acknowledgement of the work of the MedPAC staff. We have a terrific staff, and without them, we couldn't do our work. As you know, MedPAC is a nonpartisan congressional advisory body, and so our goal, our mission, our sole mission is to help you with the difficult decisions that you must make each year. Each year we produce two reports, a March report, which usually focuses primarily on payment updates, and then a June report that ranges more broadly across Medicare issues. We have 17 commissioners, as you know. 6 of them have clinical training as either physicians or RNs. 6 of our commissioners have high-level executive experience with healthcare delivery organizations, 4 high-level government experience, and then 6 academics who publish frequently in peer-reviewed journals. And some of us have more than one of these credentials. I mention the credentials to emphasize that we are people who have experience in different facets of the Medicare program, and our goal is to bring that experience to bear for the benefit of the program, the beneficiaries it serves, and the taxpayers who finance it. Because we have a lot of experience doesn't necessarily mean that we're always right. We can be right or wrong like everybody else, but you can be assured that our agenda as a commission is the same as yours: high quality care for Medicare beneficiaries at the lowest possible cost for taxpayers. Despite the diversity of the MedPAC commissioners, we typically have a high degree of consensus on our recommendations. This March report is no exception. There are 12 recommendations in our March report. That represents a total of 187 yes votes versus only 2 no votes and 3 abstentions. The March report, as I say, here's the summary of the major recommendations in the March report. There are recommendations on payment updates for each of the payment systems that Medicare uses. For physicians, hospital inpatient and outpatient dialysis services and hospice services, we're recommending a 1% increase in the Medicare rates. For ambulatory surgery centers, half of 1% increase in the rates. And then 0 update for skilled nursing facilities, home health agencies, inpatient rehab facilities, and long-term care hospitals. In the case of home health services, we're recommending a rebasing of the rates as we have in previous year, as well as some changes in the case mix system and a per-episode copay for Medicare beneficiaries. And then, as we do each year in our March report, we also do a status report on the Part C Medicare Advantage program and Part D, the prescription drug program. I want to pick up, Chairman Herger, on one of the points that you made in your introduction. This report is principally about how much the unit prices should change for Medicare services. But we can't get to where we want to go in terms of an efficient Medicare program providing high quality care to Medicare beneficiaries at a reasonable cost for taxpayers if we focus only on the unit prices. In addition to that, we must look at the relative values that we pay for different types of services. We must also look at the payment methods that we use and try new innovative payment methods that create better incentives for high-value care. And then finally, we also must look at the incentives for Medicare beneficiaries. So, Mr. Chairman, those are my summary comments, and I look forward to the opportunity to talk further about our report.
Thank you very much. And again, as I mentioned earlier, to allow our members to vote, we have 2 votes going on. We're going to recess, and we will reconvene immediately after the second vote.
Okay.
With that, we stand in recess.
Thanks.
The Health Subcommittee of Ways and Means will reconvene. Mr. Hackbarth, I want to thank you for your testimony. In MedPAC's report, you recommend that Congress should freeze Medicare payment rates for inpatient rehabilitation facilities, long-term care hospitals, and skilled nursing facilities. Can you explain what led the Commission to recommend freezing payment rates for these providers?
Yeah, I guess I have to hit that. Mr. Chairman, the analysis that we go through for each of the provider sectors takes into account a variety of different factors, one of which is their financial margin on Medicare business, where that data is available. But we also look at access to capital, the quality of services to Medicare beneficiaries, whether facilities are opening or closing. So it's a sort of a multifactorial analysis that we go through. And so the specifics for each of those sectors vary a little bit. But in general, what they have in common is that the projected margins are pretty healthy for each of those. And we think that there is ample room for efficient providers of those services to operate within the existing rates, so no increase in the rates is necessary.
Thank you. Currently, there is no copayment for home health care. In the March report, MedPAC recommends that most Medicare beneficiaries be required to pay a copayment for each episode of home health care they receive. The commissioners recommended that exceptions be made for low-income beneficiaries and those being discharged from the hospital. Could you explain why the commission arrived at this recommendation and the impact it would have on overutilization and fraud?
Yes. Well, this is a challenging issue for MedPAC. This is an issue where we actually did have a dissenting vote and an abstention, which, as I indicated earlier, is fairly unusual for us. We concluded, the majority of us concluded, the vast majority of us concluded that a $150 per episode copay was an appropriate and necessary step to help curb unnecessary utilization of home health services. As you know, home health is an area where utilization has increased rapidly, and in particular in some parts of the country. And by its nature, it's a service where there aren't clear clinical guidelines as to appropriate use of the service. And under those circumstances, we think it is an appropriate thing to do to ask the beneficiaries to pay a modest copay. To put the $150 per episode copay in context, for a beneficiary with a typical number of visits, home health visits in an episode, it would work out to about $8 per visit. So a smaller amount than that same beneficiary would pay for a physician office visit or an outpatient therapy visit. So it's modest, but we think it's appropriate. And I would emphasize the point that you picked up on, which is it's targeted to apply only to beneficiaries who are admitted to home health from the community. It doesn't apply to Medicare beneficiaries following a hospital stay or a stay in a skilled nursing facility. And there's also an exemption from the copay for beneficiaries who use 4 or fewer home health visits.
Well, thank you for that. Could you, some have expressed concerns that the addition of a home health copayment would drive seniors to other sites of care, such as outpatient facilities. Are seniors currently required to pay a copayment for the care they receive in these outpatient settings?
Yes, that's true. They are required to pay co-pays. Home health is one of the few services where Medicare beneficiaries are not required to pay a co-pay. And as I indicated, in determining what we thought was an appropriate home health copay, we took into account how much beneficiaries pay for some of these alternative services.
So in your opinion, this would not, home health copayments would not shift beneficiary to other sites of service?
That is our expectation, yes.
Mr.
It would
Bar-
not shift them, yes.
I thank you again for your testimony. Now, the gentleman from California, Mr. Thompson, is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Hackworth, for being here. In your March 2010 report, you state that Medicare is the single largest payer in regard to Medicare, in regard to health care. And you also go on to say that for the next decade, that cost is going to slow vis-a-vis the previous decade. I think it was, you're looking at 6% growth between now and 2019. It was about almost 10% in the past decade. And I'm assuming that part of that reason is because of the health care reform legislation that was passed. And the idea was to pass legislation that bends that cost curve. We heard so much about that. At the same time, creating better care, better health, and lower costs. And there was a very interesting article in the National Journal, I think it was last Friday, that it's entitled Adapt or Else. And they state that whether it wants to or not, the healthcare system is being forced to reinvent itself. The healthcare law is a clearinghouse of sorts for policies that have circulated among healthcare analysts for years, but struggled to gain traction. And isn't the truth of the matter that much of what was put into the healthcare reform bill either came from MedPAC advice or proposals that MedPAC itself put forward?
Mm-hmm. Well, certainly there were many provisions that were linked to past recommendations of MedPAC.
So bundling around hospital administrations,
yes.
That was one of your recommendations,
That's correct.
which is in there. Reducing hospital readmissions,
yes.
that was the MedPAC recommendation. Value-based purchasing aimed at rewarding quality.
Yes.
Primary care investments and expanded primary care reimbursement.
Yes.
Payment accuracy, including reducing Medicare Advantage overpayments.
Yes.
Adoption of comparative effectiveness research.
Yes.
And expanded fraud fighting authorities.
Yes.
Thank you. The other question I have is, as you know, I think firsthand, I'm very concerned about representation for rural areas. And as co-chair of the Bipartisan Rural Healthcare Coalition, we've been very, very active in trying to bring attention to that issue. And rural healthcare delivery has a lot of unique challenges, shortages of healthcare providers, and probably spills over into other underserved areas as well, but geographic remoteness, low patient volume with disproportionately high Medicare populations, limited access to integrated healthcare systems, and a lack of electronic networks to efficiently manage healthcare. And I understand that it's probably a challenge for you to and I know you don't do it personally, but it's a challenge to get that appropriateness or proportionateness on the commission. But in your report, there's not even a mention of the word rural, and I think it's kind of it's a concern for those of us who have live in rural areas, represent rural areas. Is there anything you can tell us that we can look forward to? Are we going to address this issue?
Yeah.
Are we going to get proportional representation on that board?
Yeah. Well, thank you, Mr. Thompson, for raising this. We've talked about this issue before. we share your concern about assuring access to quality care for beneficiaries in rural areas and assuring appropriate payment for providers in rural areas. In fact, the very first report that I did on becoming chairman of MedPAC is Medicare in Rural America, typically thick MedPAC report. And in every report since, every March report since, there are in fact lots of analyses directed specifically at the issue of fair payment for rural providers. Let me cite a couple examples.
I said report, I meant your testimony.
Oh,
Apologize for that.
okay. Well, in this March report, let me just highlight a couple of examples that are important. We've recommended changes in the payment systems for lots of different Medicare providers, but in this particular report, we talk about fairness in payment for skilled nursing facilities and home health agencies. And we've made recommendations in changing the case mix system used to allocate those payments. Among the benefits from those changes would be increased payments for rural providers of home health services and skilled nursing facility services. So throughout all of our reports, there are issues like that where we're trying to assure accuracy and fairness in payment, which we think is very important. Now, on the specific issue of representation, we have 4 commissioners that have significant rural experience out of our 17. We have 2 physicians and then 2 people.
Gentleman's time has expired.
Okay.
But thank you. The gentleman from Texas, Mr. Johnson, is recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks for being here today. I appreciate you saying you're out to get good value for what we spend in Medicare. I'm committed to making sure that Medicare is provided high-quality care at the same time being wise with taxpayer dollars. Your report mentions the variations between Medicare payments for the same services in different settings. Medicare generally pays more for a service in a hospital than in an ambulatory surgical center. Does this create an incentive for care to be provided in one setting over another based on higher reimbursement?
Yeah, that's our concern, Mr. Johnson, and it's a growing concern, and we see some shifts towards hospital-based services that may be driven, at least in part, by higher payment levels.
Well, are you looking to do something about it?
We are, in fact, and it's a tricky issue to deal with for a variety of reasons, but in particular because the patients are often different. So it can be the exact same service, for example, some type of ambulatory surgery, but the patients that go to the hospital are sicker on average. They have more underlying conditions. They're at higher risk of a bad event. And so they're done at the hospital outpatient department so that they're closer to backup in case something goes wrong. And so if you go to equal payment, you have to make sure that it's properly risk adjusted for the different types of patients seen in the different settings.
Yeah, I understand that, but you ought to be able to work that problem, I think.
Well, and we are working on that, and I hope we will be making some recommendations.
Thank you. So you've got a plan for studying these payment variations. I
Yes, sir.
appreciate that. Our health care delivery system needs to focus on the right procedures to the right patient in the right time and place. And does the current payment system make that hard to achieve?
It does. It creates incentives often for more costly services than are absolutely necessary for patients. And as we just discussed a minute ago, sometimes not in the lowest cost, most efficient setting.
Okay, we know you're interested in combating waste, fraud, and abuse in the Medicare system, and we've heard about the problems across all areas of the country, including reports of alleged fraud in home health services occurring near my district in Dallas. Secretary Sebelius has said that her agency is setting up new checks to screen providers before they're ever accepted into the system. Can you comment on what progress has been made in becoming more proactive rather than reactive in preventing fraud?
Well, we are not specifically engaged in the operational side of enforcement, but we have recommended that the Secretary monitor home health use for unusual patterns, very high levels of use, and that the Congress give the Secretary the authority to do things like limit new providers, limit payment when aberrant patterns of home health use are found. And so our contribution to this has been mostly to identify some of these very unusual patterns. So in some areas of the country, you'll see home health use that is like 7 times the national average. And we think that sort of analysis is a useful screening tool for the Secretary and the Justice Department to use.
And do you think she's taking your statistics and doing anything with them?
Our understanding is that they are intensifying their focus on Medicare fraud in general, but in particular in the home health area.
It's an interesting word you chose, intensify. Thank you, Mr. Chairman. I appreciate the time.
Thank you. The gentleman yields back. The gentleman from New Jersey, Mr. Pascrell, is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, I think that Glenn Hackbarth brings some unique qualities to our committee in that the recommendations from MedPAC, many of them were incorporated into the Affordable Health Care Bill, which is now the law of the land. And so when people talk about they made cuts, but they didn't get into the entitlements where the real money is. Well, we know Social Security did not add to the debt. And now they missed the point about the health care legislation because 1/3 of it dealt with Medicare and Medicaid, addressing the entitlement, but specifically adopting many of your recommendations. That's a fact of life. We can point out chapter and verse where the recommendations where the commission made are in there. This is entitlement reform. And what was the purpose of your recommendations? Well, if you read your report, and not just read what somebody else said about it, but if you read your report, you're saying that this is, you didn't use the word reform, this is changing how we look at Medicare and Medicaid. So, one of the fundamental problems we face in healthcare deliverance, I mean, no use putting a system together if we don't have the people to deliver it. So we spend quite a bit of time on workforce. I know when we're putting the legislation together, quite a bit of time. Doctors and nurses, how to get more doctors and nurses. We know about the shortages, which are going to cripple the system regardless of what the system is, and how we want to deliver it to the patient if you don't have the personnel that is properly trained, updated, etc. You offer 2 solutions, both of which were involved or implemented, put into the health care reform, which hope will be implemented. The idea of a payment reform, like paying for quality outcomes, and delivery system reforms such as medical homes and the accountable care organizations. You were very, very specific. Do you think that these reforms, these 2 reforms, will help improve the delivery of health care for Medicare beneficiaries? And more importantly, do you think that these are essential changes to Medicare itself?
Well, it's certainly our hope and expectation that those 2 reforms would both improve quality of care for Medicare beneficiaries and we hope also reduce the cost. In each case, medical homes and ACOs, there are a lot of important issues to be worked out. Each idea, I'm sure, will evolve over time, but we think that they are promising steps.
Mr. Chairman, want to bring to you, Mr. Chairman, I want to bring to your attention something now. Most of these reforms and changes were never scored. Never scored, which means we do not have a true picture of the amount of savings when we move from pay for service to proper care and help for the patient. We don't know really what the results will be. That was never scored by CBO. And I would contend to you, if you look at your recommendations and you look at very specifically the Healthcare Reform Act, that you can find areas where it doesn't take too much to conclude that there must be a savings from moving away from fee-for-service and into those specific things which you just mentioned. Would you agree with me?
Well, certainly that's why we recommended them, is that we think by moving away from straight fee-for-service payment, changing the incentives for providers, helping them focus on value, changing the organization of care delivery can result in better care at lower cost.
So those editorials and those politicians and congressmen on both sides of the aisle, I'm going to ask you the question. Let me make the statement. I've been like, when did you stop beating your wife this time?
Gentleman's time has expired.
Can I finish the question?
Very quickly, please.
And then I'll try to answer it. The question is, the editorials and those congressmen on both sides of the aisle who said very specifically that we need to get to entitlements in order for us to have true cuts.
The gentleman's
budget.
time has expired. And
Well,
I might
isn't that
mention
the
that
truth,
many of
Mr.
these,
Chairman?
you can submit, or if we get a second round, you can submit in writing, and I'm sure.
Well,
Mr.
am I
Hackbarth, but
inaccurate about
again,
that, Mr.
we're
Chairman? I'll
over.
correct myself.
Again, the gentleman's time has expired. I might also mention several of these issues that you brought up were scored, but they scored so small they weren't listed.
Many of them were
with-
not, Mr.
with
Chairman.
that,
I'll go over them one by one with you if you wish.
The gentleman's time has expired.
Thank you, Mr.
With
Chairman.
that, the gentleman from Georgia, Dr. Price, is recognized for 5 minutes.
Thank you, Mr. Chairman. In your assessment of the handout that we got, you have the volume growth increasing significantly. Can you cite for us the main drivers of that volume briefly?
So, Dr. Price, you're referring to this slide?
I think that's
Yeah.
right.
Right. The principal drivers are the top line, the red line, is spending per Medicare beneficiary. So a small piece of it is due to the annual updates in payment rates. That's the lowest line, sort of gold
Right.
update line. The difference between the red line and the yellow line is due to changes in the volume and intensity of service. So more visits, more procedures, more imaging tests, things of that nature.
What would you say would be the, are there incentivizations in the program itself that drive that volume?
Well, the amount that we pay for a service can influence volume. And one of the issues that we...
Anything else?
Differences in, burden of illness from year to year can affect volume. Changes in technology as new technology develops. Concerns about malpractice can be a factor in volume growth.
And would you say that there are folks out there in the community, in the medical arena, that are working to decrease those costs as well?
Sure.
On their own?
Absolutely.
And when we as a government or as a society identify those, shouldn't we use some of those as best practices?
Absolutely. As somebody who ran a large physician practice, that was one of the things that we tried to do most often, is learn from colleagues in other practices.
In fact, that's kind of the hallmark of healthcare, isn't it, to find what works best and use it?
At its best, yes.
Then I'd like to ask you to address, please, the issue of physician-owned facilities, hospitals, ambulatory surgery centers. All of the reports that I have seen and read, and all of my personal experience, leads me to believe that they are oftentimes drive the highest quality of care at the greatest efficiency and the lowest possible cost per patient. Yet we as a society disincent and in fact punish them for doing what they're doing. How would you address that?
Well, it's a tricky issue, Dr. Price. On the one hand, I ran a large multi-specialty practice where we brought all kinds of services in-house. And so we were self-referring to our colleagues, and we thought that was good for patients. On the other hand, there are instances where that sort of self-referral can cause problems.
Then shouldn't we be addressing then the self-referral as opposed to saying that you can't have any of those things anymore? Do you disagree with the fact that physician-owned entities out there oftentimes have the highest quality at the lowest cost per patient?
No, I don't disagree with that.
Okay.
I think that can often be the case.
Do you disagree with this? Do you agree or disagree with the statement that we, as a Congress and as a government, have put in place policies that will actually diminish the ability of those kinds of services to be in existence?
Yes, there are some policies, but here's the tricky part about it. The problem isn't physician ownership per se or self-referral per se. It's the combination of self-referral with fee-for-service payment that rewards more volume and intensity, and often mispricing of services that creates real substantial profit opportunities.
So I hear you say then that if we had a level playing field and allowed physician-owned entities to compete with other entities, level playing field, same pricing mechanism and the like, same reimbursement mechanism, that you would be supportive of that opportunity. Is that right?
The first step is to try to get the prices right, so there aren't undue profit opportunities. Second step is to try to move to new payment systems that don't reward volume and intensity, but reward better care.
Mr. Chairman, let me just say, if I may, because my time is very, very brief. I think we are missing a huge opportunity by rewarding those individuals that actually provide the highest quality care at the lowest possible cost, and in fact, we are punishing those individuals for doing what they're doing, and I look forward to my second round.
I thank the gentleman. The gentleman's time has expired. The gentleman from Washington, Mr. Reichert, is recognized for 5 minutes.
Thank you, Mr. Chairman, and welcome. Thanks for being here today. There's a movement among employers toward what people have called a value-based benefit design, where preventative, primary, and chronic disease care is cheaper for employees. And things like high-end imaging and unnecessary emergency room visits, which you sort of touched on a little bit already, or high-cost drugs, so things that have been identified as not having, anyway, proven value, are more expensive. These coverage programs are combined with wellness programs and incentives for things like improved physical activity and nutrition. There are some great examples from Washington State, including Group Health, Costco, Boeing, which all use different approaches to providing very structured, purposeful health care to their employees. Medicare, by comparison, seems to be behind the curve a little bit. Some have said maybe even in the dark ages. But Medicare Advantage offers promise, though, for coordinated care. Would you agree with that?
Yes, it would.
And MedPAC has encouraged Congress and CMS to add pay-for-quality components to the fee-for-service payment system in Medicare. But this is just one step. Could Medicare actually change its benefit structure to be more innovative and value-based? It even sort of goes to the doctor's question of best practices.
Yes. In fact, it's an issue that's currently on the MedPAC agenda, and we will have a chapter on the subject in our June report this coming June. And we're looking, hopefully, to moving towards some recommendations on redesign of the Medicare benefit package.
Would it be possible for you to share some of those ideas that you're looking at?
Well, actually,
today?
we're not to the point of concrete recommendations. We're drawn to the idea of value-based insurance design. In fact, one of the MedPAC commissioners, Mike Chernew, is one of the leading academic thinkers and behind the value-based insurance design movement.
So your discussion and your recommendations, how long has that discussion been ongoing?
Well, on this particular issue, I think we had one session last year, and then we had a session in February, and then at our upcoming meeting in a couple weeks, we'll
So your
talk about
first
it again.
awareness of this issue and discussion was started last year. You've had another meeting since. So we are sort of behind the curve here on this issue. And so we've gone a year. What's the expectation on your recommendations being presented, published?
Well, you know, I don't want to get in front of my colleagues and presume a final conclusion. As I say, I think we'll have a chapter in our June report. It could, it won't include recommendations, bold-faced recommendations, but it could have some clear directional signals. And then if we have agreement in June, we would come back next year and potentially consider specific
It could be a while
recommendations.
before we see a value-based system then in Medicare.
It will, and of course it would require legislation to change.
Right. What could Congress do to help you speed the process up, or probably more likely slow it down?
Well, we're well aware of interest in Congress in the issue, and there is a lot of interest among MedPAC commissioners. So it isn't for a lack of interest or effort, but it is a complex issue to change the Medicare benefit package.
So are we looking at 2 years, 3 years, 4 years?
Oh, I would hope if we're going to make recommendations that it would be in our next cycle. We operate on a September to June cycle, so we would take them up in the fall.
When is your next meeting?
In 2 weeks.
Is it a public meeting?
All our meetings are public.
Could you provide me with the date and time of the meeting, please?
Oh, absolutely.
Thank you. I yield back, Mr. Chairman.
The gentleman yields back. The gentleman from California, the ranking member, Mr. Stark, is recognized for 5 minutes.
Thank you, Mr. Chairman. And Glenn, thank you again for all the good work that MedPAC does. I know Mr. Herger has been concerned about copayment for certain beneficiaries who use home health services. It's my understanding that home health users are older, poorer, more frail, more likely to be female than the overall Medicare population, and I'm concerned about putting further cost sharing on this population. I gather some MedPAC commissioners were as well, given that the commission, as I understand it, was not unanimous on this proposal. What were the concerns of those who didn't support the idea?
Mr. Stark, they're much like what you just described, that the copay would fall disproportionately on a vulnerable portion of the Medicare population, which was an issue that all of us, including those of us who voted yes on the recommendation, took very seriously. And so what we tried to do was tailor our recommendation in ways that would minimize, although not eliminate, that impact. And it's also important to keep in mind, as you well know, that using copays is not new in Medicare. It's the norm in Medicare, and so and they inevitably fall on users of services who tend to be sicker in the like. So it's always a challenging balancing act. We think by having a modest copay, $150 targeted on admissions from the community, that we've tailored it in a way that minimizes the adverse impact.
Okay, and I know that you have a long history, MedPAC does, of recommending parity in payments between Medicare Advantage and the fee-for-service side. And your recent report summarizes your early recommendations about Medicare Advantage and estimates that the Medicare Advantage plans are paid on average 113% of the traditional fee-for-service. Didn't private managed care plans originally come into Medicare saying they could do more for less? In other words, for 20 years they were paid 95% of our fee-for-service rate, I believe, or thereabouts. And over time we've actually moved from demanding they do better and trying to demand that they break even. You've long recommended that there be a financial neutrality between Medicare Advantage and fee-for-service. I think that's correct.
That's correct.
And the Affordable Care Act takes steps to begin to bring financial neutrality between those two programs. Can you tell us what MedPAC is seeing in the 2011 landscape in terms of Medicare Advantage availability, enrollment, and premiums?
Yeah. Well, enrollment is up. The number of plans is down somewhat. And the reduction is primarily due to the reduction in private fee-for-service plans.
Okay.
Because of the requirement enacted, not in PPACA, but several years ago in MIPA, that fee-for-service plans could not operate if there were coordinated care, coordinated network plans available. So some of the private fee-for-service plans have left the program, and that's the single biggest factor in reduction in number of available plans. Membership is, as I say, up in the most recent numbers.
Again, thank you very much for your advice to this committee. We appreciate it. Appreciate the work you do. Thank you, Mr. Chairman.
I thank the gentleman who yields back. I now recognize for 5 minutes the gentleman from Pennsylvania, Mr. Gerlach, to inquire.
Thank you, Mr. Chairman. I have a question with regard to your recommendations relative to radiologic and other imaging services. Can you briefly give me a summary of what your recommendations there are?
Well, on the specific issue of imaging in this report, I don't think we've made any specific recommendations in this report. In the past, previous reports, we've made a number of recommendations related to how the price for imaging services is set. In some instances, we think those prices have been too high, and we've recommended specific changes to reduce the price.
So understand that there's a professional component and a technical component to the reimbursement structure, and there's already been an adjustment downward for the technical component. Is there also a recommendation that you want to implement to also reduce the professional component of that reimbursement for radiological services?
We have looked at recommendations for reducing the professional component as well.
What's that based on?
For duplication of work would be an example. When two tests are done on the same patient at the same time, the amount of work is reduced because you don't have to do some things twice. It's the same patient, same time, and that may justify a reduction in the professional component.
Okay, so are you obviously concerned about utilization overall, and therefore by reducing the professional component aspect of that, you can reduce utilization?
Well, certainly there are indications that when the price is too high, you get more utilization. People go to areas that are more profitable. They invest in equipment if there's a significant profit in that area. So it's very important to keep the prices right, as close to the cost of delivery as possible.
Is there a understanding in your review process of how the services come about to begin with? For example, if a radiologist, I'm thinking of one in one of my hospitals, who does a service based upon a referral from another physician, if there is a reduction in the professional component of that radiologist service, but the radiologist didn't initiate the service, the radiologist took a referral, how would a referral-based system, cutting the professional component for a service based on a referral from somebody from the outside, how would that affect utilization?
So what you're suggesting, I just want to make sure I understand the situation. So this is a radiologist who's received a referral for an imaging service, and you're saying if their professional component is reduced?
Yeah, as I understand what you're talking about is reducing the professional component for that service.
Well, and again, what we've talked about are making adjustments in very specific instances. For example, when you're doing multiple images on the same patient, the same visit, then we think that there are some economies in doing it that way, and it's appropriate to reduce the professional component in instances like that. We have not just said across the board, oh, let's reduce imaging services because we think we want to try to suppress utilization. We take a much more targeted approach than that.
Is it only in multiple cases of multiple services or imaging work being done with one patient at one time that you're suggesting that change?
Specifically on the work component, I think it's multiple services. There have been, in the physician fee schedule, also changes in the practice expense for physician services that have changed the payment levels for different types of services.
Okay. And in coming up with this recommendation, who did you talk to within the profession to get a sense of how patients come to undertake those imaging or have those imaging services undertaken, both referral and in some instances if the physician is able to do imaging services on his own or her own based upon how they're set up as a practice. Who did you talk to in essence to come up with the conclusion that there ought to be a change in the professional component of those services being reimbursed?
Well, one of the things that I'm most proud of in MedPAC is that we do reach out to all of the relevant professional associations. As you well know, in this particular area, there are also some coalitions of people in the imaging field, professional physicians and imaging equipment manufacturers. And we hear, believe me, often from those people and exchange ideas. All of our recommendations, when we make them, we have open public discussion. A draft recommendation is discussed in a public meeting. We solicit input from affected parties on those recommendations before we finally act. We've got a very open process.
The gentleman's time.
Thank you.
has
You're back.
expired.
Thank you.
Thank you. The gentleman from California, Mr. Nunes, is recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to yield 5 minutes to the gentleman from Georgia, Mr. Price.
I thank my friend from California for yielding, and I appreciate the continued responses that you're giving. I want to follow up on the comments that Mr. Gerlach was just making, or the line of questioning on the multiple tests. For example, if a patient is coming for a certain MRI procedure, one procedure, the costs of that procedure that are borne by the facility and by the physician involved in interpreting that are pretty much fixed, correct?
On the interpretation side or the technical component related to the equipment?
Both.
Well, the cost of operating the equipment is influenced by the volume of service provided. So you make a capital expenditure, the more you use that equipment, the lower your unit cost for the capital expense. You spread it over more units.
The machine doesn't know whether it's one patient or two patients that are getting the two different procedures, right? And the volume is the number of procedures itself. It's not how many patients there are.
That's right. It doesn't matter whether they're distinct patients or not.
So you got a patient who's coming in for an MRI of a cervical spine and a patient who's coming in for an MRI of a lumbar spine. Those two procedures are separate, distinct, require the use of the machine itself, the technical side, and then the interpretive side. The physician is using his or her best knowledge and information and expertise to interpret that. You wouldn't say that that had a volume component, would you?
In terms of interpreting?
Yeah.
No.
Okay, so the physician side ought to be fixed, you just said, right?
The professional
we ought not decrease physician reimbursement based on whether or not it's one patient or two patients.
Well, based on whether it's one versus two, no. But as new technology, imaging being one example, becomes more widely used, more frequently used, I do think it's reasonable for the cost per unit of service as the experience level goes up to go down. That happens in almost every market for every service in the economy.
I might be able to buy it if it were two C-spine MRIs on the same patient at the same time. But we're talking about two different procedures on the same patient requiring the same use of the machine and the different brain power of the physician involved to interpret it. And so it's astounding to us, unless your goal is to simply decrease the cost, not worry about the quality and the access. If your goal is simply to decrease the cost, then that might make sense. But if you're interested in maintaining access to care and maintaining quality to care, then many of us believe that you're cutting right at the core of it.
Yeah, well, a couple points are key here, Dr. Price. First of all, the method for setting the relative values, as you know, MedPAC does not do that. CMS does not do that. An AMA-sponsored RUC does that. So it's people from the professional societies sit down together and determine the relative values for the work elements.
And if a specialty society says, no, that's not the appropriate reimbursement for this procedure, do they have any ultimate authority in that?
There is a very elaborate process.
Do they have any? Who makes the final decision?
The ultimate decision on the fee schedule is in CMS.
There you go.
But the vast majority of cases, they adopt the recommendations from the AMA-sponsored RUC.
Can you name a single procedure that's because the cost that the government reimburses physicians, pays physicians for the care, allows for the access to care, right?
That's cool. Sure.
Okay. So can you name a single procedure for which physicians are being reimbursed in real dollars more today than where they were 15 years ago?
Not off the top of my head.
Yeah,
but
I'd love to have you get back because I don't think there is one. And I say that in all sincerity and honesty. What we are doing is drastically limiting the access, availability of patients, your mom, your folks, seniors across this country, to access to care because of how we're dealing with reimbursement issues. And that's where we ought to be looking for.
Well, what I'd like to do is if we could put this slide up. The Medicare payments to physicians have been going up quite rapidly, in fact.
If I may, Mr. Chairman, the payment per for procedures, for physicians, for visitation, the cost of a patient to come to an office for a visit is drastically reduced from where it was 15 years ago.
Yeah, and I'm not trying to be argumentative, but there's an important point here, Mr. Chairman. So the unit prices, you and I would agree, the increase in unit prices, the price per office visit, the price per procedure has gone up relatively slowly. That's that bottom line on this graph. But the amount of income that physicians get from Medicare has gone up rapidly. That's the red line.
In real dollars, Mr. Chairman, if I may, in real dollars, the inflation-adjusted dollars, that line goes below the axis, as you well know.
The red line represents a 5.5% increase, average increase per year per beneficiary since the year 2000.
The gentleman's time has expired.
Thank you.
If time permits, we may try to go for a second round of questionings. Now the gentleman from Oregon, Mr. Blumenauer, is recognized for 5 minutes.
Thank you, Mr. Chairman. Welcome, Doctor. Nice to
Good to
see a
see you.
Northwesterner here, an Oregonian if I dare. Before I get to my questions, though, I want to just allow you to finish your thought that you had with my good friend from Georgia, because we watch a certain amount of well, different impulses. You know, there are some who suggest that the solution to exploding Medicare costs is to basically voucher this and index it at a level that is dramatically below the cost of inflation, medical inflation, something that would be the curve going down. And if there are problems associated with, I mean, you folks try and split the difference. I mean, you are cognizant of the problems. You deal with the practice patterns. You recommend year after year after year after year to Congress and administrations things that could help bend that cost curve. There's quite a bit of bipartisan pushback over the years. I mean, that's not political. I mean, that's just because people get pinched and they don't want to reduce that cost. My impression is that as we constructed the Affordable Care Act, that we actually included most of the recommendations they don't have maybe the teeth that some would like. They don't implement them instantly. There are too many maybe pilot projects and test this, but they're there. I am curious if you want to just finish answering the question, because if the spending per beneficiary is going up compounded over 5% per year, it suggests that there's a whole lot of procedures and a whole lot of more expensive somethings that are going on there. And I just want to make sure you're able to complete your thought.
Right. So I guess I'd summarize our view on this with a few points. One is, overall, it's our sense that there's enough money in the physician fee schedule. Medicare pays enough for physician services overall to assure adequate access for Medicare beneficiaries. However, we're concerned about how the money is distributed. We think we pay too much for some types of services and too little for other types of services. Primary care would be an example where we're worried that the payments are too low. So we think some redistribution of the payments is appropriate. And then finally, we think it ought to be a high priority goal for Medicare to move to new payment systems that don't just reward more volume and intensity, but reward higher value care for both Medicare beneficiaries in the program. I would agree that just holding down the unit price increase the way the yellow line has is not the best way to get good care for Medicare beneficiaries.
And that, of course, is why we attempted to have a comprehensive approach that incorporated these elements in, and hopefully they can be implemented sooner rather than later after they're tested, to be able to make a system that does reward healthcare value over volume.
Right.
And I find it a little bit ironic that some of my Republican friends talk about massive cuts in, for example, in Medicare Advantage, when in fact it's a move to try and deal with the quality of the system, and they propose to replace it with something that would be far more draconian than any modest adjustment in Medicare Advantage.
And Mr. Blumenauer, if I may, could I just pick up on something?
I only have 30 seconds left, and I gave
absolutely.
3 minutes to you to try and finish.
You were generous. I'm sorry. Go ahead.
No, but there's just one area that I wanted to leave for your review, because we're watching palliative care and hospice kind of merge. And there is an opportunity for us to be able to give higher quality care for people, and we used to talk about just in the last 6 months of life, but we're finding because of palliative care, because of changes in treatment patterns, sometimes people in, quote, hospice live longer than people who are given intensive treatments ICUs and expensive and really painful chemotherapies. I'm wondering if there's a way going forward that we can work with you to think a little bit about the recalibration of what hospice care means, ways that are better meet the needs of patients and families, actually might end up being less expensive, but certainly better care.
The gentleman's time has expired.
Thank you, Mr.
The gentlelady from Tennessee, Ms. Black, is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Heckbarth, I want to go to the issue of outpatient settings, and your report verifies something that I've heard within the district, and that there is a significant variation in the amount of Medicare payments for similar services that are provided in outpatient settings, with Medicare generally paying more for services that are furnished in a hospital outpatient department than in an ambulatory surgical center or in a physician's office. And this variation, of course, results in an undesirable financial incentive, such as those ambulatory surgical centers being organized as more a hospital outpatient department, at least in part to receive the higher payments. Does the Commission have a plan for studying this? And if so, do you have a sense for where those policy options will be that may result from this review?
Yes, it is an issue that we're actively looking at. We are concerned that the disparities in payment for the same service based on the location where it's provided can cause problems, and there's some evidence that, in fact, it is causing problems. As you indicate, people are converting to hospital status simply for to get the benefit of the higher payment, and clearly that's a problem. As I indicated earlier in response to Mr. Johnson's question, it is a little bit tricky in the sense that although the service might be the same, for example, a given ambulatory surgical procedure, the patients receiving it could be different between the ASC and the hospital outpatient department. And I know this from experience, having run a large group. We did surgery in both ASCs and hospital outpatient departments, and we would send, quite consciously, the more difficult patients to the hospital outpatient department. Same surgery, but they're riskier patients because of comorbidities and the like. And we wanted them to be at the hospital in case something went wrong and we needed backup. Because they were sicker patients, we paid the hospital more for the same surgical procedure than we paid the ASC. It was an adjustment, in effect, for the higher risk of the patient. So what we need to do is move towards equal rates for the same service on a risk-adjusted basis. And that last part is the tricky part in this that we're looking at.
Thank you, and that certainly makes sense. But at the current time where you look at apples to apples, it doesn't appear to be that way. So I think that certainly is a wise thing to take a look at. Additional question, in your latest report, the Commission notes that beneficiaries who receive the Part D low-income subsidy, they account for nearly 22% of all enrollees, and yet they use more than half, or they reach the donut hole. More than half of them reach the donut hole. Further, these low-income subsidy enrollees account for about 2 million of the 2.4 million enrollees who have reached that Part D catastrophic spending cap in 2008. Your report also notes that the average per capita spending for the low-income subsidy enrollee were double that of the non-low-income subsidy enrollee. And I know that these low-income enrollees are probably, for the most part, sicker and they require more medication. But this disparity really is very alarming. Do you have any recommendations on how we might be able to better control the costs for this population?
We've not looked specifically at that. We have done some research that suggests that there may be differences in risks that aren't fully captured by the existing risk adjustment systems, and that may be a reason for the higher utilization. Because you're talking about a low-income population, The tool of using copays to try to limit excess utilization is not one that's readily available. These are people that don't have much income and appropriately need to be protected from excessive copays. If we don't do that, then there's the risk that they won't get needed drugs and we'll have higher costs.
And I don't discount that, but I think what I have seen, at least in my experience as an emergency room nurse, is that when people have an opportunity to have a smorgasbord or more services available for them, they tend to overutilize those services just because they're available. And I'm not casting any stones there, because if we all go into a buffet, we eat a whole lot more food on the buffet than we would if we ordered an individual plate.
Right.
And so trying to get at how do you do a better job with making sure that the services that are being required are actually services that are really needed and not just being utilized because they're there.
The gentlelady's time has expired. The gentleman from Wisconsin, Mr. Kind, is recognized for 5 minutes. The gentleman, the ranking member, is recognized.
I asked just unanimous consent to put this National Journal article from Mr. Thompson.
Without objection. The gentleman from Wisconsin for 5 minutes.
Thank you. Thank you, Mr. Chairman, and thank you, Mr. Hackbarth, and your staff for your update that you're giving us today. And I think this is a very important hearing, just hearing the recommendations that you're making. We appreciate all the work that you put into this and the effort to provide us guidance on where we're going to go with the Medicare program. Now, I noticed in your January 2011 report, you reported on various geographic variation in the healthcare system, utilization variation. And you found in that report that one area that was high in one area of utilization tended to be high in all areas of utilization. In fact, you also specifically noted that the area with the greatest service use, Miami, is nearly twice the level of utilization than the least use area, which is my hometown of La Crosse, Wisconsin. And yet, in the report then and today, you're not making any recommendations on how to deal with this geographic payment variation or utilization variation around the country. I'm wondering why you're not being a little more explicit in the recommendations, and will you in the future provide greater guidance in this area?
Well, we think, Mr. Kind, that the best way to reward high-value healthcare delivery, whether it's in La Crosse or perhaps a provider in Miami, is through changing the payment systems, moving away from fee-for-service payment to new payment methods.
I agree, but are you going to come out with some specific proposals on how to do that?
We have made many proposals: medical home, ACOs, bundling around hospital admissions, many of them picked up in PPACA. And so we think payment reform is the best way to move to value.
Most of that's already in the Affordable Care Act.
That's correct.
Again, relying on your recommendations in the past, but what about systematic payment reform under Medicare?
One of there's a lot of discussion in recent years about geographic variation, and one of the points that's I think been missed in that is that we can talk about regions of the country and how Florida is more expensive than Wisconsin, but there is variation within Wisconsin. There's variation within Florida.
Right.
And so if you apply a geographic approach and say we want to reward Wisconsin, penalize Florida, there's going to be a lot of collateral damage.
I agree, and that's the point. And that's the point that many of us have been trying to make for the last 2-3 years, is this geographic variation is occurring within congressional districts, within communities itself. So it's less Wisconsin versus Florida as it is from individual providers, no matter where you find them. And that's the point on payment reform. And you even recognize on page 4 of your March report, you're right, we recognize that managing updates and relative payment rates alone will not solve a fundamental problem with the current Medicare fee-for-service payment system, that providers are generally paid more when they deliver more services without regard to the quality or value of those additional services. I think that's going to be the key and the ultimate verdict on healthcare reform. If we can move to a different reimbursement or payment system that rewards outcome and value, that I think is going to solve a lot of the problems as far as the cost curve that we were just talking about, but also the quality of care that we're striving for out there. And I was hoping MedPAC throughout the years would have been a little more affirmative in the recommendations and how we can get there, other than just through pilots like ACOs and medical homes and bundling, which is all necessary and good, but something more dramatic in proposal.
Well, the challenge that we have, everybody says that fee-for-service is bad because it rewards volume and intensity of service. And for sure that's true. But from my perspective, the worst legacy of fee-for-service is that we've got a fragmented delivery system.
Right.
Where people don't work together to improve care for patients. They all, in too many instances, they operate separately, they don't communicate well, they don't coordinate well. And the difficult thing about payment reform is that you can change payment methods, but there has to be somebody at the other end to receive it.
Right.
There has to be a reorganization
I
of care
agree,
delivery.
and you're probably aware that, again, under the Affordable Care Act, two things are going to happen, both through the Institute of Medicine. They're going to have an update for the first time on the Medicare reimbursement formula, using real data, real time, instead of the proxy data, which I think is long overdue. But secondly, and most importantly, they've embarked on a 2-year study now to come up with an actionable plan to change fee-for-service to a fee-for-value reimbursement system. That then can go to the administration and the IPAB Commission for implementation, which I think is going to be key. And that's already moving forward under healthcare reform, which again I think is going to be the key to sustaining the system that we have in a much more affordable basis, but getting better outcomes too. And the thing with the the accountable care organizations, medical homes, bundling, that's fine for pilots, but it's basically saying you need to structure yourself in this fashion to be rewarded. Instead of saying you're going to be rewarded for value and outcome of care, you figure it out as far as what's the best approach to achieve it. Because obviously smaller groups are going to have a little more difficulty than the larger providers to form an ACOs or some type of medical home model. Wouldn't you agree?
Yeah, in fact, one of the challenges with small providers, for example, physicians in solo practice, is it's difficult to assess their performance because of small numbers and risk selection.
That's right. Thank you.
Everyone has asked a question. Maybe there's a couple members that would like to ask a second question, so we will begin to move to that. The gentleman from Georgia, Dr. Price, for 5 minutes.
Thank you, Mr. Chairman. I look forward, there's so many questions. I look forward to being able to provide some for you and respond in writing. The Part A, primarily hospital services, Part B, primarily physician services, described. What else, what percent of Part B is physician reimbursement?
Actually, to MDs as opposed to other health professionals.
Yes.
It's about 12 or 13% of total spending is for physicians. Is that the number you're looking for, or what share of Part B is physicians?
Well, both, but 12 or 13% is fine, because I think there's this sense by many that if you just whack away and whack away and whack away at the docs, that you'll be able to control the costs. And in fact, if we continue as a society to whack away at what the physicians are able to gain for their services, for their caring, compassionate, knowledgeable services, we will truly harm the access to quality care in this country, because physicians just say, I can't do that anymore. I can't do that anymore. And that's what I hear from my colleagues, former medical colleagues at home and across the country, who say which is what I was trying to get to with the previous line of questioning on not having any significant increase in reimbursement. And all insurance pegs itself to Medicare now, basically, in terms of reimbursement. So the federal government controls the payments to physicians for virtually every single procedure in this country. I want to talk about a couple other items, though, in the short time that I have available. You mentioned about the RUC, having the ability to have significant input into the costs, that payment for physician services. You also agreed that it was CMS that had the final say. The RUC itself, as I understand it, has significant responsibility for about 90% of the service, the cost, the payment for the services that are provided. That number may or may not be right. About half of Medicare visits are through primary care. Yet the number of primary care physicians on the RUC is in the teens, and maybe even lower, maybe even single digits in terms of a percent. How do you reconcile that?
Well, certainly that's been a sore point among primary care physicians, that they felt they've been underrepresented and that the process is skewed against them in various ways.
Isn't that part of the problem, though, of setting up the kind of apparatus that we currently have, is that you rarely, if ever, can get to the right answer because you rarely, if ever, have the right people in the room?
Yeah, Medicare has very complicated payment systems, as you know. Better than most people, I'm aware of not only the complexity, but also some of the weaknesses. The problem, however, is that it's not like we can say, oh, it's these Medicare administered prices or prices set by the competitive market. As you just indicated, private insurers tend to say, oh, Medicare's way is better than what we were using, so we're going to adopt Medicare's fee schedule.
So what we have is essentially a price fixing from the federal government.
So it is a difficult system, but there aren't clear, better alternatives. Just one point on how private...
There are clear, better alternatives, and I look forward to that discussion.
Well, I would look forward to that as well. But let me just make one point about how private insurers use the Medicare system. Typically, what they use is the relative values. But they set their own conversion factor.
Yeah, let me talk a little bit about...
the price is not the same.
No, it's true. It's 90% or 110% or 130%. Let me talk about one of those relative values, and that is the E&M codes, the Evaluation and Management codes, which are the doc visit codes, if you will. My understanding, what evidence, what science went into the setting of those codes? Are you aware of at the initiation of the
Well,
argument?
the original system back in the early 90s was based on an extensive research project done by Bill Schau at Harvard to set initial relative values, and then the RUC process was established for purposes of maintaining the system ongoing.
And maintaining is the right word, because there hasn't been a as I understand it, a critical evaluation of the E&M codes and what we are incenting in terms of office visits and punishing.
Actually, by law, there is a 5-year review. Each 5 years, they do a comprehensive review of the work values. And that doesn't mean every single code, but it's a far-reaching review of the work.
And it compares to what has been. I would suggest it compares to what has been the occurrence, as opposed to looking at whether or not we're getting the desired effect.
In fact, a critical question in the whole system is, do we want to base the prices for different services on estimates of the cost of producing them, or do we want to take into account the value of the service to patients?
Which brings me to a value question. All of the values comments seem to imply that every single patient can have an ideal outcome regardless of the diagnosis and regardless of the clinical status. How do you pay for value in a patient who has a terminal disease, is at the end of life, and needs caring, compassionate care for that, yet will have a lousy outcome?
Right. Well, when I talk about pay for value, I'm talking about number one, looking at population served and not individual cases. As I think you're pointing out, individual cases, sometimes they're unavoidable bad results. That's not a sign of poor care. So you look across broader populations, you risk adjust for the underlying conditions, and you use measures that take into account things like patient satisfaction. It's not just outcomes. A terminal patient could receive good care, acknowledge that it's high quality, humane care, even though it's a bad outcome.
The gentleman's time has expired. The gentleman from Washington, Mr. McDermott, is recognized for 5 minutes.
Thank you very much, Mr. Chairman. I was sitting down in my office watching this on the television, and I decided I better come up here and ask a question.
Okay.
Because I think the least known committee in the medical industrial complex in the United States is the RUC and the impact that they have. And I would like to submit for the record a graph from the Medical Group Management Association Annual Physician Compensation and Productive Survey. It's 1992 to 2008. And you can see when the RUC started, and the top line is the specialist income, and the bottom line is primary care. And so I started looking at the RUC and figuring out who's on the RUC and how do they do this. And they clearly submit their recommendations to CMS, and 9 times out of 10, or more than that, maybe 95 times out of 100, the CMS accepts their recommendations. Is that correct?
That's correct, yeah.
So it is not being set by CMS, but it's being set by a private committee controlled by the American Medical Association. Is that correct?
That's correct. I would point out that what we've recommended, and this was 2 or 3 years ago now, is that CMS take a more assertive role and not just be a passive receiver of recommendations, but be more directive in what they need to look at and change the dynamic that otherwise exists within the RUC. And they've taken some steps in that direction.
I would like to submit another article for the record, which is from the New England Journal of Medicine, dated 22 March 2007, which says that in 2006, the RUC recommendations, MedPAC went up on 227 services and down on 26. So there has never been any bending of the curve on the basis of the RUC. Is that correct?
And that's precisely our concern. You know, the dynamics of the RUC are that there's lots of incentive to identify a service for higher payment. There's very little incentive to collect data to document, oh, my service ought to go down. And so what we have said is that CMS needs to redress that imbalance in incentives within the RUC by directing them to look at particular services that are likely to be overvalued.
Do you think it might be better just to collect your own data and never mind the RUC? I mean, why should the Medical Association be setting their own fees? How are you ever going to get control of costs if you let the fox decide what the keys to the hen house are going to be used for?
Well, what we've recommended is a hybrid approach, where CMS does not turn over the keys to the fox, is much more assertive in the process, but then takes advantage of the expertise of the relative specialties to provide input to that process. So it's a rebalancing of the system. We think marrying professional expertise with data analysis done by CMS.
How about a rebalancing of the components inside the RUC?
Well,
my looking at the list, depending how you look at people, what you can figure out is that mostly it's specialist, or it's a balance heavily weighted toward specialists, not toward primary care physicians.
And that too is a concern of ours, and certainly it's a concern of many of the primary care physicians and the relevant professional societies.
It seems to me that the biggest problem that those of us who are supporting of the President's plan still have about what's going on is that controlling costs is still not very well done. We've done well in access, in including more people through the exchanges and that sort of thing, but the question is ultimately going to be, how come we're spending 16% of GDP or 17% of GDP, and the Swiss are spending 11%, and the French are spending 12, and whatever? What is that? Where is that 5% coming from? Is what I've been looking at, trying to figure out. And I keep coming back to the fact that Medicare allowed usual and customary fees in the original legislation, and we are continuing it in this with RUC as simply an extension of that, as I see it. Am I misreading the facts?
No, we believe that how Medicare pays for services is an important contributor to the level of expenditure and the rate of growth. If we ever want to reduce the rate of growth, let alone reduce the level of expenditure, if we ever want to improve the value we get for our Medicare expenditures, we need to change the payment methods.
The gentleman's time has expired. The gentleman
Thank you,
from
Mr. Chairman.
New Jersey, Mr. Pasquale, is recognized for.
Thank you, Mr. Chairman. Mr. Chairman, I looked over the report from the Centers for Medicare and Medicaid, the CMS report of April 22nd of 2010. That also is an interesting document. And I just wanted to clarify something we started to get into before. On the previous question, clearly the CBO and the CMS scored all the legislative language. I misspoke. Trying to get to the point, I didn't finish my point before. It did score all of the words in the 970 pages or so. That health care reform bill, in that bill, in the act, they did not give as much credit, though, the point I'm trying to make, to delivery system reforms that we believe, those of us who support the legislation, support the act, will lead to better care at lower costs.
Right.
We had Mr. Chairman, we had the CMS actuary here, if you remember, in this room last month.
Right.
I asked him why these provisions weren't credited with more savings. Of course, if you look at the chart, they go each one of the provisions, and you see a lot of zeros, of course, and you see a lot of low numbers and some other things. But things we were talking about before, the pilot testing for pay for performance, the technical corrections to hospital value-based purchasing, support the patient-centered medical homes, which is only a small part of this. There is the whole list in the report, which we were provided. It's very, very clear. The question, what we're saying is, those of us who support the legislation and the act, why we think that these things will lead to better care and lower cost. Or else why the hell did we put the bill together in the first place? We had the actuary here, and I asked why these provisions weren't credited with more savings than the charts would indicate. So you can score it and not give credit for the savings. I don't think that's a score that, we proudly wait for the results because we didn't get any results. They said we don't have enough information.
Right.
Is that correct?
That's my understanding of why they didn't.
And he answered this. He answered that he believed in their potential to save Medicare money.
Right.
He stated for the record, but that he didn't have enough data to estimate the amount of savings they would be given. How am I doing so far?
I think you've accurately described the situation. The concepts can be sound. The concepts have to be turned into operational payment systems. And then you have to get providers to convert to those new payment systems. There are uncertain connections there. And
not unlike the changes we made to Medicare since its beginning in the 60s. We've made dramatic changes to the Medicare program. Made dramatic changes to, and when we prognosticate, when we went out from the point that we were at. So this is not unusual. This is not something that we can say, well, what is it going to be in 2022? I mean, the charts here go up to 2019.
Yeah.
I think they're very optimistic. But I hope that all of us recognize these provisions. These provisions are the breadth and the width of Medicare and Medicaid entitlement changes. We are changing business in the Health Care Act, aren't we, Mr. Hochbarth?
That's certainly the goal. That's why we recommended the various provisions that we did that were included in the law. We think that they have the potential to change.
So if these ideas in health care reform which would move us towards paying for the quality of care rather than the quantity of care, something my friend from Wisconsin keeps talking about. I would assume everybody understands. I know that there will be pushbacks from the medical profession, certain parts of the medical
Gentleman's
profession.
time is expired.
And you've heard them. Cannot be identified as entitlement reform, then what the heck can be? Thank you, Mr. Chairman.
The gentleman's time has expired. Mr. Hackbarth, the Commission intends to consider different approaches to updating physician payments in an attempt to provide options aimed at fixing the SGR problem. Can you preview the timing and the substance of Commission's work on this pressing issue?
Yeah. Our hope is that we will have recommendations in the fall, draft recommendations in September, final recommendations for vote within the Commission in October. That's a hope. We've got to obviously do a lot of work between now and then and forge a consensus on what to do. The work we think is urgent. It's motivated by a growing concern among MedPAC commissioners that the SGR is a growing threat to access to services for Medicare beneficiaries. I want to be clear, we don't see wide-scale evidence of that right now, but our concern is that the repeated difficult process of trying to avert large-scale cuts in physician payments and doing that over and over, sometimes multiple times in the same year, the cumulative effect of that exercise is undermining both physician and beneficiary confidence in the Medicare program. So for a long time, I've been able to sit before the subcommittee and say, yeah, SGR is a problem, but we don't see an imminent threat to access. We think we're getting closer to that tipping point. And so we are looking at options for potentially addressing that. Just, if I may, Mr. Chairman, just one last point. I don't want to create the false expectation that we can come up with a new payment system that is not going to have a budget score attached to it, that the big SGR budget problem is going to go away. I don't think that there is a rational policy option that's going to make that number go away. I think the question for the Congress is not whether we're going to spend more than the SGR baseline says. I think everybody in this room, the CMS actuary, the Medicare trustees, everybody knows we're going to spend more than the SGR says we will. The only question now is whether we're going to spend more by making last-minute adjustments, plowing more money into the existing payment system, or whether we're going to spend more strategically to achieve important goals for the Medicare program. We think the latter course is the wise course, and so my hope is that we can develop a package that will have a cost, a budget cost to it, but will achieve some important goals for Medicare reform going forward. That's our goal. Now, whether I can, get the consensus within MedPAC, I won't know until we're further into the process, but that's the mindset that I have.
Well, I thank you for your comments, and I'm sure you know this is a bipartisan major concern.
It is.
That as members of Congress, each of us deal with it. We talk to our physicians. It's one that we need to place, and it's important for you to know, as I'm sure you all do, that this is a high priority of us, of this committee, certainly of this subcommittee. And again, I want to thank our witness for your testimony today. As a reminder, any member wishing to submit a question for the record will have 14 days to do so. Mr. Hackbarth, if any questions are submitted, I ask that you respond in a timely manner. With that, the subcommittee is adjourned.